Welcome to the About the Face podcast, sponsored by the American Academy of Facial Plastic and Reconstructive Surgery through the Facial Plastic Surgery and Aesthetic Medicine Journal.
Welcome to About the Face, where we explore the innovations shaping facial plastic and reconstructive surgery. I'm your host, Allie Burgess. Today we're joined by Dr. Matthew Miller, director of the UNC Facial Nerve Center. We're discussing changes in smile symmetry and perceived emotions in patients with facial synkinesis after Depressor Anguli Oris myectomy, a long-term follow-up study. It addresses a common patient counseling gap. Short-term improvements after DAO myectomy are clear. Do they persist after a year or two or later? Dr. Miller, thank you for being here.
Thank you for having me, Naomi. It's great to be on, and I'm glad we are talking outcomes because it's really exactly the question patients ask when they're in the clinic room with you. Will this improvement last? Will this improvement be permanent? They've often done Botox before, but they really are seeking that long-term improvement in their smile. And so that's what we wanted to look at.
Great. So before we get into the data, for those listening who may not be as familiar with the procedure, can you define what a DAO myectomy is?
Of course. But first, let's just discuss synkinesis because recently Dr. Sam Boyer got a group of us together, about 20 clinicians from around the world, to try to standardize the nomenclature because some people were referring to these patients as non-flaccid facial paralysis. Other clinicians were referring to them as post-paralytic facial palsy. Others as aberrant facial nerve reinnervation syndrome. Honestly, it was confusing to clinicians, so certainly it was going to be confusing to patients. And so we all agreed to use the term synkinesis to describe this clinical condition. Now, in patients with synkinesis, let's talk about the Depressor Anguli Oris. So that is a muscle that folds the corner of mouth and should be activated when somebody is trying to either display disgust or trying to show sadness. However, in synkinesis, two things happen. First, due to the miswiring that occurs as a patient recovers from Bell's palsy, Ramsay-Hunt syndrome, and the other causes of synkinesis, this DAO muscle often becomes too strong. The second thing we often see in synkinesis patients is that the DAO co-activates with the smile muscles when the patient attempts to smile. So if you imagine the triceps activating at the same time as you're flexing your biceps muscle, you won't be able to curl your arm because these opposing muscles are going against each other.
So we've all seen early symmetry after DAO myectomy in many of the audience, but we also know that improvements after other myectomies like the platysma, the DLI, or the orbicularis can sometimes decrease or drift by 6 or 12 months after the procedure. So your paper provides a durability check on the short-term outcomes for what we see after DAO myectomy. Was that the initial intent of the study?
Yes. So first, we want to know if improvements in smile symmetry, the emotion the patient is able to convey with smiling, persist beyond 12 months after the procedure. And then second, we want you to test whether the 3-month postoperative result is a reliable predictor of long-term outcomes. To do this, we looked at a set of outcome measures. We looked at blinded clinician rating, and then objective computer vision tools. And a group of us just met at the International Facial Nerve Symposium to standardize outcomes, and we did all agree that it's very important to collect clinician-rated, objective, and patient-reported outcomes like we did in this study.
Great. So you essentially combined the patient perspective, the clinician eye, and then quantitative data to back it up. For people wondering, does this series represent my personal clinical patient population? Who did you include in your study, and how did you measure the changes?
Yes, 50 synkinesis patients who underwent DAO myectomy between August of 2021 and December 2023. And importantly, Each patient had at least 12 months of follow-up. The median age was 45. We did have the majority females, 84% were females. And not surprisingly, Bell's palsy was the most common etiology. Our median follow-up was about 22 months, and some patients we followed for longer than 3 years. Importantly, all photographs and videos were collected at least 3 months after their last Botox treatment, so Botox was not in effect. And we excluded patients who underwent any other smile reanimation procedure except for DAO myectomy. And we measured the outcomes in 3 ways. Patient-reported facial function and quality of life using the face or the facial photometric evaluation survey. We used blinded clinician grading using the eFace. And then we had 2 different objective metrics. One was a Motrix, and then the other was an automated facial expression analysis called Face Reader. A Motrix uses landmarks to measure important clinical movements, such as upper lip slope, oral contour, height and position, and interlabial distance and area. Face Reader is an automated facial expression software that analyzes 3 videos to see what emotions patients are showing when they smile.
Got it. So that seems like a representative group, and controlling for the Botox definitely matters. Can you walk us through your patient selection criteria, especially when you're considering a DAO myectomy?
Yes. So all patients with Synkinesis who present to our clinic, they start with facial therapy and neuromuscular retraining with one of the 2 therapists at UNC, the University of North Carolina. Then if they had DAO tightness and Synkinesis present on physical exam, we perform a DAO muscle block using 1% lidocaine with 1 to 100,000 epinephrine, as this is very predictive of what their DAO myectomy outcome will look like. And that's one of the things I love about this procedure is you can predict it before you do the surgery with this simple muscle block test. Then, if their smile symmetry improves after DAO block, we discussed DAO myectomy as a first step in smile reanimation. Importantly, patients who primarily have lower lip asymmetry, when they smile, they're not going to be great candidates for DAO myectomy, as taking out the DAO muscle does not impact lower lip symmetry with smile. It really only affects the oral commissure and the upper lip. And then the other population to be aware of is patients who have a lot of resting asymmetry due to tightness in other muscles on the affected side. They also may do better with procedures such as upfront selective neurectomy to be able to address this resting asymmetry as well as their smile asymmetry.
So say you have decided that a patient is a good candidate for DAO myectomy and they want to proceed. How do you perform the procedure?
We perform this procedure in clinic using local anesthesia. We make about a 3 centimeter intraoral incision. There's no scar for the patient. And this incision is just posterior to the medullus. And we resect a small strip of buccinator muscle just to access the DAO muscle. Once we isolate about a 2 centimeter segment of the DAO, extending inferior into the medullus, we then use bipolar and we resect just about 2 centimeter segment of muscle.
Thanks. That's a helpful description. So what are some of the outcomes from the patient side first, from their perspectives in the patient-reported surveys? What did people report back after the procedure?
Yes. So on the face survey, both the total score and the smile self-score had significant improvements at last follow-up. And roughly 71% of patients reported a better smile when they were asked at their last follow-up visit. Importantly, we also saw patient-reported improvements in eating and drinking, tightness in their face, and in social function. So the benefits showed up in everyday life, not just in photos.
That's great. And that kind of mirrors what we see in the short term for follow-up. When patients have an improvement in their smile, they have less tightness, better oral function, and then that translates to more willingness to be out in public and an effect on their psychosocial awareness as well. Now, from the clinical side, how did the blinded E-FACE scores look?
Yes, E-FACE showed significant improvements in oral commentary excursion with smile, increasing from 42 to 58, and this was a significant improvement. Not surprisingly, other domains of the E-FACE did not significantly change, which makes sense because the DAO myectomy procedure it just improves smile symmetry. And of course, patient-reported facial function like we've already talked about.
Great. So those exam findings definitely line up with what the patients report. Now, onto the objective metrics. How did those compare?
Yes. So we used Emotrix Plus, the automated facial landmark software. And this software showed significant improvements in upper lip symmetry, oral contour position with smile, and dental display with smile. And these improvements in smile angle, oral contour excursion, and dental show are important. At very good research shows they all work together to impact the emotions a patient conveys when they're smiling.
So that's a really important point to capture because most smiles aren't one vector problems. It isn't just the difference in the oral commissure. So beyond symmetry, how did the smiles actually read to the outside world?
Yes, and you said exactly right, because it all comes down to helping the patient show more happiness when they go to stop, because that's why we smile. We smile to show happiness. And we use this face reader software to objectively analyze 3-second smile videos, which tell a much fuller story of how our patient is doing compared to still photos. During these videos, patients conveyed about 13% more happiness when smiling and fewer negative emotions. Both of these changes were significant. And this increase in happiness conveyed with smiling is why this procedure can be so powerful. Because when we can't show happiness when we smile, we do not smile, which can be mentally challenging for patients. And some of the best feedback we get from this patient population after DAO myectomy is that they have started to smile more. They don't mind taking pictures, and they even now try to take pictures a little bit more. And this really is the best feedback we can get.
That's a really important point because the impact of patients when they feel like they can't exhibit the emotions that they want to, I think we've seen in patients that lets them to believe that their face doesn't match their mood, which then translates to the public perception. So that impact is really important. So for durability, did these improvements hold past a year in your study?
Yes, we did not see the decline in results, which are often reported after other myectomy procedures. And practically speaking, the 3-month postoperative result is a reliable forecast of long-term outcomes, which is important because you can use this data back in the real world to counsel patients when they come back for their 3-month postoperative visit. If they still are not happy with their smile, we can discuss possible next steps, which typically is the selected neurectomy surgery. However, I do want to emphasize that there's no rush to perform neurectomy surgery. This surgery can be performed at any time. It is not a time-sensitive surgery per se. And there is a little bit more unpredictability, more risk associated with neurectomy compared to a myectomy. And so you want to make sure patients are ready from both a physical and, just as importantly, a psychosocial standpoint prior to moving on to this next step, this selected neurectomy surgery.
Absolutely. And especially assessing that psychosocial standpoint, it's important to talk to the patient, have that conversation to manage their expectations. And your study enables you to tell patients that the outcome that you see at 3 months may be similar to what you can keep after the procedure longer term, and then you can plan accordingly. Why do you think that the DAO holds up when other myectomies sometimes don't?
That's a great question. And I think it all goes back to the anatomy. And so while the DAO muscle is very wide at its mandibular origin, it becomes very narrow and tubular shaped halfway up as it approaches the medalis. We are able to fully resect this superior half of this muscle, this tubular portion. And very good research shows that the further severed muscle stumps are from one another, the less likely the muscle is to regenerate and to reconnect. So I think this extent of resection likely explains why recurrence is not as much of an issue after DAO myectomy compared to other selective myectomy procedures such as the orbicularis oculi, the Depressor labii inferior Oris, and platysmectomy procedures.
Got it. That definitely makes sense when you think about the underlying anatomy of the muscle itself. So what typically happens after surgery for these patients in terms of recovery, now that we've talked about the long-term outcomes?
Yes, so patients typically recover fast, which again is another beautiful thing about this procedure. We can perform it in clinic under local anesthesia. We typically do it Thursday mornings. If they take a long weekend, they're back in work, they're back doing all their activities by Monday. The bruising and swelling resolve within those first few days. And then we see them back about 3 weeks after surgery to make sure that they have healed as expected. And this 3-week point is also when they resume facial therapy and neuromuscular retraining. Because again, surgery certainly does not replace neuromuscular retraining. These two treatments are very much synergistic with one another.
That makes sense. So do you typically counsel patients about neuromuscular retraining before the surgery?
Absolutely. And as I mentioned earlier, we always start with therapy and neuromuscular retraining so that these patients are very used to it by the time we add in the procedure.
So it sounds like clear expectations upfront are very important for good patient care, especially in this scenario. And your study highlights one way that a measurement of this can then translate into the conversations that you have with patients. Do you have any other clinical pearls, especially pertaining to DAO myectomy?
Of course. So first, use the DAO muscle block to preview the benefit and then align expectations. And we published our technique back a couple of years ago in FPSAM. And this is important because it, first of all, makes sure a patient is going to be a good candidate for the procedure. And it also allows the patient to see in real time what their smile is likely to look like once you take out the muscle. 2, you want to make sure you have performed a full thickness resection. And you confirm this by visualizing the subcutaneous fat once you have resected the DAO muscle. And then third, it's all about expectation setting with patients. And sometimes I even know there's a good chance we will ultimately be performing selective neurectomy in patients due to hypertonicity and synkinesis in other muscles, but it still may make sense to start with DAO myectomy. And as long as patients know there could be subsequent procedures to further optimize their function and that we're taking a stepwise approach, they're okay with it. They're not surprised when they may need selective neurectomy down the line. And also, while most patients, by the time they see us in clinic, they understand that they're not going to get their pre-facial paralysis smile back, this is a point I always make clear to patients when we meet. Our goal is meaningful, but still incremental improvement.
Absolutely. And this reconstructive ladder where you can have a stepwise approach within facial reanimation procedures makes the field so interesting and specific to each patient. For your study, were there any limitations that we should keep in mind when we interpret the results?
Yes. So I think the two big limitations. One is because we did require each patient to have at least 12-month follow-ups, that does introduce the possibility of potential selection bias. The other thing we did not have in this study is we did not have a therapy-only control group.
Got it. So to recap, the Symmetry improvements hold beyond a year for the DAO myectomy, and the 3-month smile predicts the long term. Patients don't just have a straighter smile, but they have a perceived happier smile in terms of the emotional impact. And this has really helped to quantify and qualify the DAO myectomy procedure and help with patient conversations preoperatively and to prognosticate how they do postoperatively. It's really great to discuss your paper, Changes in Smile Symmetry and Perceived Emotions in Patients with Facial Synkinesis after DAO myectomy. Thanks, Dr. Miller, so much for sharing your work.
Thank you, Ali. It has been a pleasure, and I appreciate the chance to translate the data into what it means for day-to-day care with patients.
Wonderful. That's it for this episode of About the Face. The full citation and outcomes details are in the show notes. See you next time.